Hello everyone. So this is the continuation of the lecture benign breast disease, and we were left with the fibroadenoma, galactocele, and I also include one more topic in this Phyllodes tumor in addition to breast abscess. So let us continue with the lecture, and this is, you can see, a fibroadenoma which is having clear cut capsule, and it is a well defined structure, but the cyst is different from fibroadenoma, as you already know. Now, what is fibroadenoma? It is a type of ANDI. ANDI is aberration in normal development and evolution. You have known this by the previous lecture. So, this is the most common benign tumor of breast. It occurs usually below 30 years in females. And the important point is they usually arise in fully developed breasts. So, it is not common in girls which are very young, and in 20% it is bilateral, and in 20% of the cases it is multiple. So this, it occurs between the age of most commonly 25 and 15 to 25 years of age, and it may also occur occasionally in older women. It arises, you must be knowing, from the hyperplasia of a single lobule, which is usually growing up to 2 to 3 centimeter in size, but it may even grow larger. I'll tell you what is that called. It is surrounded by a well marked capsule. You have seen in the picture. The excision is not required in all the cases. You must be knowing this because patient may be panicking with the swelling in their breast. So what is the reason of not requiring excision in all the cases? Because it does not turn into malignancy. But there are some indications for surgery. The first one is if the patient wants for cosmetic reason at her choice, the giant fibroadenoma, which is more than 5 centimeter and fast growing, should be excised. When the size of the fibroadenoma is more than 3 centimeter, it should be excised. When it is multiple in number, it should be excised. And when there is suspicion of malignancy, it should be excised. Now there are variants of fibroadenoma. One is juvenile fibroadenoma, the other one is complex fibroadenoma. Juvenile fibroadenoma occurs in adolescent girl. It may clinically mimic Phyllodes tumor. So I'll tell you what is Phyllodes tumor. The complex fibroadenoma, in this there is fibrocystic changes like apocrine metaplasia, cyst formation, sclerosing adenosis is there. Occasionally they may turn into malignancy, so they require excision. Now the clinical features are, it is painless swelling which is smooth, firm, non-tender, well localized, and moves freely within the breast tissue. That's why it is called as mouse in the breast. Axillary lymph nodes will not be enlarged in this, mind you. Now there are microscopic changes, which is intercanalicular change and pericanalicular change. The intercanalicular change is large and soft stroma. The intercanalicular is large and soft. Stroma is mainly cellular with distorted duct. In pericanalicular, the feature are, it is small and hard. The stroma is mainly fibrous with normal duct. Now the investigations which are required are FNAC. Definitely you can do FNAC from the swelling and get the diagnosis. It may be ultrasound guided also, or blind also when the swelling is well palpable ultrasound. If we do not want to do FNAC, it can be done, and if we are sure that the thing is benign, ultrasound may be done to confirm whether the swelling is cystic or solid in nature. Mammography can also be done in this case. In fibroadenoma, it will be shown as well localized small irregular shadow. Now the treatment is 30% of fibroadenoma may disappear or reduce in size in 2 to 4 years. 10 to 15% will increase in size progressively. The small fibroadenoma do not require treatment, but regular follow-up should be done at 6 month interval. The excision which when done should be either in general anesthesia versus if they are very small, you can do them in local anesthesia. Now, there are two incisions which are used when the fibroadenoma is small and in the vicinity of the areola. The circumareolar incision is given and it is cosmetically good. When it is big, the submembrane incision is given. So, circumareolar incision or submembrane incision for big fibroadenomas. Now, let us move on to the next topic, that is galactocele. You know, this is a milk-filled dilated duct. Now, it is a retention cyst caused by obstruction of lactiferous duct, which contains milky substance or milk with the epithelial debris. You know, they occur in women almost always during or shortly after lactation and usually resolve after cessation of breastfeeding. So this is the typical features which will be getting in history taking. When you examine the patient, you will find that at a soft to firm, usually soft, small or large cystic mass which may be fluctuant and non-tender. The surface is palpable, maybe in subareolar location. Thus, equally can be calcification in this galactocele, which may mimic carcinoma. Then maybe infection of galactocele that will lead to abscess formation. The treatment is either aspiration or excision. So abscess, if there is abscess formation, incision and drainage will help. Aspiration may not help. Antibiotic cover should be given if ANDI is done. Now next we will move on to the breast abscess. It may be of two types, lactational abscess of the breast or non-lactational abscess of the breast. So we have seen in the galactocele that breast abscess can be a complication. Let us continue now. Lactational abscess of breast is commonly seen in lactating women. Precipitating or predisposing factors can be cracked nipple, retracted nipple, improper cleaning of the nipple, inadequate milk sucking by the baby or milk expression causing stasis, infection from the mouth of the baby, and hematoma getting infected can be the cause of abscess. So clinical features are continuous throbbing pain in the breast and fever is there, diffuse redness and tenderness and induration may be there, purulent discharge from the nipple may be present, entire breast may get involved eventually. The treatment is initial stages may be given antibiotics with repeated USG guided aspiration. When there is no improvement, drainage under general anesthesia is done. The counter incision can be made. I'll show you what is counter incision. The non-lactational abscess of the breast is commonly occurring in ductectasia and periareolar infections. The common organisms in this are bacterioids, anaerobic streptococci, enterococci, and gram-negative organisms. Commonly a recurrent and tender swelling under the areola is the feature of this. Now the treatment is again antibiotics, repeated aspiration, drainage, and maybe later you can do a cone excision of the breast. So this I'm explaining the counter drainage. So if you have given incision here or incision here, the opposite counter incision is called as the counter incision, and you can pass a drain from incision to counter incision for the drainage of or adequate drainage of abscess. So the last topic for today is Phyllodes tumor, important topic. So you can see the picture. Dilated veins, pressure necrosis, bosselated surface are the features of this. Its name is cystosarcoma phyllodes, but it is rarely cystic and only very rarely develop features of sarcomatous tumor. It metastatizes by bloodstream, so lymph nodes are usually not present. It is a benign tumor, also called sarcocystic disease of Brody, or you know that cystosarcoma phylloid. It occurs mainly over the age of 40 years but can occur in younger women. Now the presentation is large, sometimes massive. You have seen in the picture tumor with an unevenly bosselated surface. You have seen the surface also. Occasionally ulceration of the overlying skin may be there because of pressure necrosis. So you have seen all the things, the dilated veins, the bosselated surface, the use swelling you can say, and the pressure necrosis. This you can say is the ulcer formation also there. Despite their size, white tumor remain mobile on the chest wall. This is an important thing to note. Histologically, there is a wide variation in appearance with some of low malignant potential resembling a fibroadenoma and others having higher mitotic index, which are histologically worrying. The treatment is enucleation, but we should not favor enucleation. At least we should do wider local excision. But when the tumors are recurrent and those with malignant type will require mastectomy. So thank you so much.